Welcome to this Scottsdale Interventional Forum talk on structural heart disease. We're going to be talking today about a case presentation of TAVR and severe aortic insufficiency. My name is Saif Anwaruddin. I'm an interventional cardiologist, and these are my disclosures. So moving on to the case, this was a patient that we treated at our institution a few years ago. He's a 79-year-old gentleman with a history with symptoms of progressively worsening fatigue and dyspnea. His medical history is notable for a mitral valve and tricuspid valve repair with a Mays procedure in 2011. He has undergone permanent pacemaker implantation for complete heart block, COPD, atrial fibrillation on anticoagulation, hypertension, and coronary artery disease. He is noted to have progressive symptoms that have been worse over the past month and a half prior to presentation, an NYHA class 2 to 3 by symptoms. On examination, he's remarkable for a diastolic murmur, noted as left sternal border. He underwent non-invasive and invasive imaging. This is his TEE images, which shows evidence of a prior mitral valve repair with trace MR, some smoke in the left atrium, and what appears to be severe aortic insufficiency from his native aortic valve leaflets. We then went on to CTA imaging. A couple of things to point out here. His annular dimensions, as noted on the right-hand side, show an annular area of 501 square centimeters with a perimeter of 81 millimeters. And his sinuses are noted here with an average diameter of 34 millimeters, so large sinuses and a large annular area as well. I think it's important to point out here that his aortic valve is trileaflet. The challenging aspect of this is that there is minimal, if any, calcification, which is important when we're talking about implantation of a transcatheter aortic valve into the annulus for treating aortic insufficiency. Without sufficient calcification, their concern is sufficient adhering of the valve to the tissue to allow it to be stable after deployment. Furthermore, it will also affect valve selection in terms of self-expanding versus balloon expandable versus at that time it wasn't available to us, but a mechanically expandable valve like a Lotus valve, for example. And we also take into account the ascending aortic diameter on the CT scan. For this particular case, our preference was for a self-expanding valve, which we'll talk a little bit more about, but the ascending aortic diameter can help secure that the top of the valve, particularly the evolute valve, in place if it's not too large, helps in helping to stabilize the valve in the annulus. Furthermore, this is an CT image of the relationship between the aortic annulus and the mitral valve ring. As you can see here, its position and its relationship, while it's not directly there next to the aortic annulus, there are sutures there, and we do hope that some of that will allow the anchoring of the transcatheter valve in place, given its proximity to the aortic annulus. Again, further imaging, what's sort of most notable is the absence of any real calcification in the aortic root or annulus. And on the right-hand side, dimensions of the vasculature to facilitate transfemoral delivery of the transcatheter valve. So in summary, 79-year-old gentleman with prior mitral valve and tricuspid valve repairs, permanent pacemaker, atrial fibrillation, hypertension, with severe native valve aortic insufficiency and worsening symptoms over the course of a month and a half, and due to his prior medical history and frailty, felt to be higher risk for open surgery. Now, when we approach this case, there are certain challenges that we have to be aware of and address as part of our case planning and how we work the case up. One is obviously the lack of annular and valvular calcification. This is not always the case. There are plenty of cases with aortic insufficiency where there's mixed disease and is calcified, so it facilitates placement of the valve in those situations. Appropriate oversizing is important, and this really applies to self-expanding valves. You can't really you really can't oversize a balloon expandable valve too much. But in this case, the self-expanding valve in native aortic insufficiency without the presence of calcium, we tend to aim for at least 20% oversizing based on the measurements. And finally, what is our plan to ensure stability with valve deployment and positioning in terms of the procedural, the valve selection and how we go about deploying the valve as well. For the purposes of this case, we decided to go with a 34 evolute R, given the size, oversizing requirements, the size of the sinuses. We planned to go with transfemoral access, although some would consider transsubclavian or transaxillary access here, as you have better one-to-one feedback and translation of your motion from a subclavian position as compared to the femoral position. But given the fact that you have great vascular access and you could be done fully percutaneously at that time, we decided to go with transfemoral access. We placed a temporary venous pacemaker, and this procedure was going to be performed under general anesthesia with TE guidance. We felt that TE imaging was going to be very helpful in assessing the stability of the valve and also our positioning. This is sort of different from our traditional practice where we're mostly conscious sedation or monitored anesthesia care without transesophageal echo guidance, reflecting somewhat the complexity of this procedure. This is the angiogram with the pigtail and the non-coronary cusp. You can see make a couple of observations here. One, you see the annuloplasty rings, both the tricuspid, the mitral, and the position in relation to the aortic annulus. You can see the absence of any significant calcification in the annulus, and obviously the amount of aortic insufficiency noted there. On the right-hand side, we have the 34 valve in position, probably about 2 to 3 millimeters into the below the annulus, without the capsule retracted yet. The capsule was retracted and the valve was deployed and aortic contact was made, and you can see on the left-hand side, our catheter is clearly on the greater curvature of the aorta, and our valve deployment is a little bit canted, with the valve being deeper on the non-coronary side versus the left coronary side. This was, as the valve was positioned and we made annular contact and we regained pressure, we attempted to pivot the catheter off of the greater curvature of the aorta, thereby raising the valve on the non-coronary side by being careful with the left coronary side so that we don't lift it up, but rather pivot it off. And you can do that with the wire in position as seen here. In doing so, we obtained a better position and we were able to deploy the valve in that position. It was relatively stable, likely for two reasons. One, for the oversizing of the ascending of the top part of the valve with relation to the ascending aorta, and perhaps some scar suture material in the LVOT area where the annular ring is, to help stabilize that. But we had no major issues with stability, and we were able to pivot that valve off the greater curvature of the aorta and then deploy it fully. And as you can see on the TEE, there is no aortic insufficiency residual after the procedure, and the mitral valve is functioning normally. The patient did well and was discharged home a couple of days later and continued to do well in follow-up. Just a quick slide on data. This is data from the STS ACC TVT registry that we published, looking at self-expanding valves for the treatment of native aortic insufficiency with TAVR. We found several interesting observations. First of all, that we found that despite the technical challenges, when done successfully, this procedure was able to reduce moderate to severe and severe aortic insufficiency for the most part to mild to less than trace and trivial aortic insufficiency, both at post-procedurally and 1 month in the vast majority of patients. Now, in terms of patients' outcomes and with regards to mortality, there was an early hazard that was likely attributable to a couple of factors. One being the technical challenges associated with the procedure that some of which we talked about, but also the patients and their and how sick they were. But in those patients who were able to survive that early hazard, the subsequent 1-year survival in the landmark analysis showed that the patients actually did pretty well. Again, this is an off-label procedure and an off-label indication for TAVR, but in absence of a dedicated device for a transcatheter device for aortic insufficiency in patients who are considered to be high risk or inoperable, this seems to be a reasonable option with careful case planning and understanding the technical limitations and challenges that one can face. So thank you very much, and I appreciate the opportunity to present.